This is Blood and Cancer, the official podcast of MD Edge Hematology Oncology. I am the voice of MD Edge Podcasts, Nick Andrews.
This week on Clinical Correlation, National Doctors Day.
And I'm joined this week, as I always am, by the editor-in-chief of MD Edge Hematology Oncology, Dr. David Henry. And Dr. Henry, we're doing video. We're both recording video. It might be available on YouTube or something else. And I must say that under the appropriate light, you and I look pretty good.
Well, it's quite true. We do look pretty good, so I hope our viewers will
agree.
Take a stroll down to the YouTube or whenever they may get a podcast that has video as well. And we're doing a really interesting recording tonight with an infectious disease doctor who's in the front lines. So if you want to introduce her, I'll tell you a little bit about what she said.
Yeah, absolutely. The interview, as you mentioned, is with Dr. Zainab Shahid and it's about hematology and COVID in the front line. And of course, as we ramp up with COVID-19, we can't say that enough. The podcast, we aim to provide relevant clinical information that can maybe help you make a decision or further conversation as much as possible for boots on the ground, specifically as it pertains to hematology and oncology, and that's what we have for you tonight.
Yeah, and Dr. Shahid did a wonderful job. The reason we're both in video tonight is I've had to learn how to do telehealth video and audio, so it's a whole new world of interacting with outpatients whom are better not coming into the office if at all possible with all of this social distancing. And she went through, and it's a really nice interview about the do's and don'ts that we keep hearing about, the social distancing, the hand washing, and some interesting information about, the N95 masks are in very short supply. Many places that are hotspots, New York, LA, are running out of this material. And some recent information is that surgical masks, while not as exquisitely defensive as the N95, the virus now, the coronavirus, COVID-19, is a droplet borne, and those surgical masks do a very good job with that. So I think that's new information, which we'll hear about and is also now out in the general media. And one more thing before we talk to our other part of our podcast is those of you who have listened to Dr. Mason do part 1, part 2 will be coming up a little bit down the road of how to use Google and YouTube and all things computer. He is also very good at protecting himself from the virus, and remembers when the SARS epidemic came out and you could get it by touch on surfaces. If you take the mail, this is how he processes the mail, and put it in the oven at 190 degrees, it will not catch fire, and after 30 minutes, your mail is entirely sterile. Good to know.
Yeah, I not necessarily the most practical information for all of us out there, but certainly relevant in these times. I guess before we talk about clinical correlation, which as always accompanies our interview at the end of the episode, just take a moment and ask how you're doing. What do you think of telehealth, and how is the hospital responding to COVID, and how are you in general, mentally and physically in Philly?
Well, it's I find it really tiring because you have to try and do all that you do every day with patients and keep your hematology and oncology straight and treat them or talk to them, and then also keep yourself straight. You worry about yourself, your family, your office. And so that's been tiring. On the outpatient setting, because we want to have people not there, virtually anyone who doesn't exactly have to be there is sent home. I'm only now in the office 2 days out of 5 because the rest I'm at home working and doing the telehealth and on the video. So that's very different. I'm currently not doing inpatient work. Some of the youngsters are, to keep us seniors away from the inpatient. My turn will probably come around right at the peak, so we'll see.
Yeah, and of course you can find all of your up-to-date COVID-19 information as it pertains to hematology, oncology, or really anything, including a couple new FDA and CMS orders and regulatory changes that happened as early as this week, which is the first week of April in 2020. Let's talk about clinical correlation with Dr. Ilana Yurkiewicz. She does something very poignant. It's always a good time to do this, whether they be your colleagues or your friends and family or mentors, mentees, or just the people who treat you. National Doctors Day was this week as we record this, and Ilana, Dr. Yurkiewicz, takes time to thank doctors in her life, but also takes time to thank a lot of other people who wear scrubs and work in the hospital, janitorial staff. uniclerks, who I've heard are perhaps the most powerful people in all of medicine, nurses, techs, et cetera. And so very poignant time to say thank you, in my opinion.
Couldn't agree more. And I actually did a thank you today. I did my noon conference. It was my turn today to give noon conference to the house staff. So of course it's nothing in person. It was all go to meeting. And you could see who's there. So about 30 of our young house staff watching. And I took time at the end to thank them. And found out, of course, they're lonely. They see patients, but they don't run into other doctors. And just thank them again for what they're doing in the front lines. Those of us of a certain age remember Legionnaires, remember HIV. And this is, while it's a worldwide pandemic and much more dramatic, when you're one-on-one with a patient who you don't know what's going on, it's frightening. And so they have to deal with that a lot. And wouldn't want to go to our recorded interview yet without mentioning a shout out to our colleagues in China.
Yes.
A very nice review from some of our colleagues who are listening in China to Blood and Cancer. So we really appreciate it. Thank you for the nice review and hope you continue to enjoy it.
Absolutely. So we have some geographic data. I want to tell all the listeners out there that Apple and Spotify and Google, all these people do an elite job at protecting your data. It's impossible for people to tell where you are, but we just can kind of get some general numbers about countries and states, and growing in China, which is pretty great. I'd like to thank our listeners in China who are fighting both hematology and oncology battles, as well as COVID-19 on the front lines, dating all the way back to late 2019. I also wanted to take a moment to address some trends in podcasting. For those of you that are really invested in the media, maybe you listen to popular shows like Stuff You Should Know or Pardon My Take or The Daily. Podcasts in general have experienced a 20% decline, Dr. Henry, because obviously people aren't working out at the gym. They're not commuting. They're not listening to podcasts. I just wanted to take a moment and say that statistically, we're doing fine. We'll be here through thick and thin. Everything at MD Edge and Medscape is going really well. We're here to provide you in this time of need as much information as we can about COVID-19 as it pertains to hematology oncology, and we'll be back when the storm settles with everything up to date in hematology oncology, clinical reviews, and as much information as possible. So if you read that, and don't worry, Blood and Cancer is not going anywhere. We'll be back and better than ever, hopefully each and every week. And as things grow, perhaps we'll get the studio quality mics and cameras that all of you are just dying to see, Dr. Henry and I. Yeah, I do.
Very good.
Yeah, absolutely. So, without any further ado, let's get to this. Let's get to this interview about hematology and COVID-19 on the front line.
Welcome to this podcast. I'm your host, Dr. David Henry. You're listening to Blood and Cancer, our weekly podcast that airs every Thursday morning from wherever you might get your podcasts. And you can also find us on our online electronic journal, mdedge.com/hematology-oncology. And this week, of course, in the face of what's happening to all of our medical lives around the country, I'm delighted to be talking with Dr. Zainab Shahid, who is Clinical Associate Professor of Medicine, and she works at the Levine Cancer Institute, part of the Atrium Health system, where she's Medical Director of the Bone Marrow Transplant Infectious Diseases. And Dr. Shahid, thank you so much for joining us today.
Pleasure. Glad to be here.
Well, we're very glad to have you because with your background as physician in practice and infectious disease, we thought you'd be unusually qualified to see how things are changing in our medical lives. And so I thought we might discuss how our practice of medicine has changed. I suspect our audience is seeing a lot of CNN and the online and TV news with some specialists like one of my favorites, Dr. Tony Fauci, updating us. But maybe we could begin with how has your practice changed with educating your trainees? Our medical students, I'm at Pennsylvania Hospital in Philadelphia, our medical students were sent away about 2 weeks ago and they're just gone. And that's a whole different world. I'm not actually aware how they're continuing both the early years when it's lecture and the later years when it's clinic. But how about educating your trainees who need to keep learning as well as helping us take care of these patients? How are you educating them, I suspect, virtually?
The world has changed definitely for us as educators because similarly in our hospital, our residents there are residents available who are not who are allowed to work in certain situations, but definitely not working in areas where there is suspicion of a person of interest with COVID-19 or a confirmed case of COVID infection. Also, in our infectious diseases teaching service, currently only the attending is seeing patients, whereas there may be some virtual sessions for education with the residents. However, there isn't any old-fashioned rounding, clinical rounds, teaching rounds, microbiology rounds whatsoever. So the world has changed. As far as our fellows are concerned, they are going to be our backup. I think they're the third line or fourth line backup where they may have to run services if our first line or second line physicians or providers fall sick with the infection. So the world has changed. We are trying to do our best in educating our residents, nurse practitioner students, and medical students, but definitely it has become an effort to provide them with the same experience that we would have in the absence of pandemic.
So to elaborate, if I could, because that's such a good point. I think we've done the same thing here at my hospital. Traditionally, as you said, the med student goes in to get a consult ready for you on infectious disease, then the house office and then the attending, and everybody goes in. And so you're saying that we dial that way down to one person. So on the COVID potential ward, it's just one person. How about on the regular ward? Is it still the classic model, or is it just one person seeing the patient, not the team?
So it depends on the ward. Most of the rooms, it is suggested that only the attending goes in. However, it's not as strict. We do have a universal mask policy, so anybody who does go into any patient room at this time in acute care setting is wearing a mask. And however, it is suggested that it do not go. We don't have any medical students or any nurse ACP residents at this point in time. There are residents present, but the rounding is very limited at this time.
Okay. And then on to education, which has so drastically changed. I'm giving a lecture next Wednesday on hematologic malignancies, and I'm going to be the only one in the Department of Medicine conference room. Our Department of Medicine has chosen to use GoToMeeting. I think we've heard about Zoom and one at Penn called Blue Jeans. And I think Twitch is more for social media, non-medical. So how are you teaching and trying to keep your noon conferences and grand rounds, so forth, going?
So because this is just occurring in the area, right now for this month, our teaching rounds are canceled, such as grand rounds. Smaller level rounds are still all obviously virtual at this time in the spirit of practicing social distancing. And so we are using Skype meeting platform. We are using WebEx meeting platform, and there is some, but officially within the healthcare environment, we're not using Zoom at this time. Skype is a major platform for broadcasting meetings and rounds.
Interesting. So I guess we're all struggling to find it, and you may have experienced this maybe at home in the evening. I'm doing some telehealth, so my practice is more outpatient than inpatient as an oncologist, and we're trying to do for routine visits where it's talking, especially in new patient visits, they're requiring us to do a telehealth video using the Blue Jeans platform, sometimes Zoom, and then in person, my clinic's dialed way down, and you have to get your chemotherapies, you have to be there for that. But when I'm doing these sometimes at home or in the evening, there's so many people now, I think, doing professional, and then so many people who are forced to quarantine at home, they're bored, and so they're streaming movies and content. And you may have heard of the game, if you have young children, called Happy Party, where you can invite everybody in and play a game. Everybody sees each other. It's kind of like a room of Zoom. So you do mostly inpatient, not outpatient telehealthing?
So outpatient, what we're trying to do, because I see a very selected group of patients, most of my visits are phone visits right now. And we are in the process of setting up a virtual platform. Traditionally, as you know, the oncology and hematology practices, especially in institutions where there is bone marrow transplant and more complex care, there's always been face-to-face patient care. So we are trying to moved to a virtual video conferencing platform, but we're not up and running just quite yet. And so we're basically phone visits, face-to-face visits with pre-visit screening for symptoms of influenza-like illness / upper respiratory tract illness. And if they are having those symptoms, they are asked to do through drive-through testing and then come to the facility. And we will hopefully move for new consults to virtual platform in the next week or so. So it's a work in progress. There's so many moving parts of this whole new virtual world for us.
Well, it's becoming so true. It's becoming clear to me that it depends where you are. I'm sure some folks in the Midwest wonder what's the huge big deal, and then, of course, New York is just on fire with the epidemic. Maybe we could share and take advantage of your infectious disease background. What's it like in Charlotte, and I'll compare Philadelphia. So how are things going in Charlotte in terms of who's testing positive and hospitals overflowing or not?
It's interesting that you asked that question because we had a huge discussion today regarding how our curve is going to be different from possibly New York City. We are a city where they're not housing as close as such as in New York City. The transport system is not as well established, or commuting is not similar to New York City. So what is expected is that our peak is going to be slow, but we're going to flatten out, or we're going to continue to see these cases. So that is the expectation that how it's going to look like. We have in our county today 250 patients positive. We are just starting to pick up our cases and starting to see similar situations where about 10 to 15% getting admitted, and then of those admitted ending up in the ICU. So we've started to see that trend, but our peak is not, we haven't reached our peak, but the expectation is that because of the structure of the city, our peak is going to look very different than some of the densely populated and cities such as New York.
Well, I think when this is all over and someone writes many books about what just happened, I think that'll be one of the chapters on where were you and how bad was it and what was done about it for exactly the reasons you say. I think in Philadelphia, we're 90 minutes down the street from New York. We're nowhere near like New York, but I think we're a little worse than you. And every city is gearing up with their resources. We are shelter in place by our governor in the state of Pennsylvania, which of course includes Philadelphia. And my first grade teacher daughter, the whole school system has been shut down in the state as well, and all the teachers are probably going to be teaching from home throughout the rest of this year. How about if we take advantage of, again, your infectious disease knowledge? So we have some drive-by setups set up now. I was talking to one of the doctors, actually, who was in line checking the cars, and when he didn't have anybody in front of him, asked him, can I just pull up and get tested? He said, yes. I said, can I just pull up and get tested if I feel and look fine? He said, well, we'll probably tell you to go home and not get tested because, of course, this is a precious resource. So whom are you suggesting go in the drive-by testing? Whom should just wait and see what happens to stay home?
So I believe at this time, because we're starting to see a community spread in many communities around the U.S., I would recommend all symptomatic patients, especially from a oncology, hematology perspective, immunocompromised patient, be tested, because that will impact not only how they would do, but also their treatment plans and so forth.
Sure. So
any symptomatic patient.
Well, now, how symptomatic? Can you elaborate? What symptoms? Don't worry, or yes, you should come in.
So that's a very interesting question, because here in our area, here's a huge allergy season is already kicking in. So we're trying to put in a huge effort to emphasize the symptoms of COVID-19, which is fever, along with cough and shortness of breath, knowing that some of our immunocompromised patients may not have a fever. So there is a lot of education around being, careful about your symptoms, monitoring them very closely. It is important that we differentiate or educate our patients as providers regarding allergy symptoms, which is mostly, nasal congestion, post-nasal drip, runny eyes, those sorts of things. When you start to have a fever with persistent dry cough or shortness of breath, I think, and some body aches, which have been associated, and occasionally GI symptoms, I would suggest that reach your primary care provider for testing. Now, it's interesting that you say that the folks who are driving up are being tested here in our area. However, we have to schedule them or allow them to be tested based on their clinical criteria. So it's not likely an open drive-through area. It has to be approved by some kind of provider for them to be tested.
Interesting, yeah. So it is a little different. I think it's changing almost by the hour of what we worry about and what our region is doing and what we could do. I then wanted to ask you, you probably heard as we speak this morning, the Prime Minister in the United Kingdom, in the UK, has had those symptoms just as you suggest. He had a dry cough, temperature of 100, and not quite short of breath, but body aches, and so he got tested and he's positive. Now, so someone calls you with that symptom, when a colleague says, I have a patient like this, what are you recommending that colleague do for that patient, which I suspect you get these calls all day long?
Yes, that's my life right now, day in and day out. And I am encouraging testing for these patients. And we try to facilitate that, especially for the immunocompromised folks, to be tested so that we can, prevent further spread of infection. I would encourage testing in all of these situations, because it would not only help preventing the spread of infection, but also epidemiologically will help us gear up for what's to come next.
Yeah, and actually you use that great buzzword, immunocompromised. So in my world and your world, we see anybody from nothing to major. And so, of course, from my oncology hematology practice, I'm getting calls from, gee, I had my breast cancer treated 10 years ago. Am I immunocompromised? What I'm saying to patients, and you correct me, I'm saying the virus is not smart. It's got into you. So either someone is too close to you, the social distancing of 6 feet, because presumably you can explain why the 6 feet, if you would. And then you can put your hands anywhere. Your hands can get infected. But they then go to your mouth and your nose, and or perhaps even your eyes, and they come in. So I say to those patients who are remote cancer or heme malignancies and not active that, yes, they might, especially if there's comorbid disease, they might do worse, but they can't get infected more than the next guy if they practice the safe practices I just mentioned. So am I right on or off the mark?
I completely agree with you. The sort of what I educate my patients is that if you have received chemotherapy in the last 6 to 12 months for a hematological or oncological malignancy, that's a good marker that your immune system is trying to recover from it. Definitely will depend what kind of chemotherapy they've received, whether it was lymphodepleting or not. However, it becomes important that I try to give them an idea of how soon the chemotherapy would have been. Obviously, I'll take out the bone marrow transplant recipients from that category. For those, I am giving a time period about 12 months to a year, 2 years, depending on whether they were allogeneic or autologous. But active chemotherapy treatment within the past few months to a year, I think, is a good indicator that they might be immunosuppressed compared to the other. If it is a remote history, I agree with you. I think that they should feel confident that it's been way in the past and my immune system would have had a chance to recover from that chemotherapy by now.
Okay, and that reminds me, speaking of chemotherapy, to mention a curious caveat. One of our oncology chemotherapy nurses lost her sense of smell. And she didn't feel that bad, but she heard about this, and so she got tested, and she's positive. Are you seeing that?
We are seeing a variety of symptoms, and honestly, they haven't really followed all the three things that we would want to say. We've had people present with fevers and myalgias, and they're positive. We've had people who had a little bit of cough and maybe a little bit of temperature. This is one of the oncologists in the area that I'm referring to. He turned positive. So there's a variety of symptoms, and I think the key thing is to be aware of where you are in the society. If you're a healthcare provider in any form and shape, you got to rush to be tested so you can prevent infection. And so I think it is you just have to have that level of awareness, especially where the community is with community spread, because you may have very mild symptoms, and 80% of the people have mild symptoms. So,
I think that's so important to underscore, because we're all panicked, and especially our patients who don't share maybe the wisdom we have of infectious disease, and 80% will get through it.
And they would be just fine.
Yeah.
And so I think that's the important part in educating the providers and the patients. However, as provider, we obviously have to take extreme measures so that we don't infect any immunocompromised folks that we potentially might be seeing. But from a community perspective, I believe that we should be aware that the diagnosis of COVID-19 is not a death sentence.
Well, boy, underscored. I'd agree. And finally, wanted to go to some anecdotes / maybe information on prevention or treatment. So, of course, it's making the rounds that Advil either helps you get it or makes it get worse. And then that, of course, goes over into the whole NSAID category. Are you hearing any of that? Is it still anecdotal?
I think we are, since because it was sort of publicized or talked about on the media and the social media, the science is unclear. And if there is any truth to that, I do not know. But we have been encouraging to stay away, not because we think it's harmful, it's because we don't know enough.
Right. Exactly, yeah. Lack of knowledge. And then I think probably you have more to say on something we're doing in our hospital here, hydroxychloroquine, if you're fairly symptomatic, not in the ICU. Then if you're in the ICU, the Ebola drug might. So those are two maybe helpfuls.
That's right. And then we're trying to, one thing I wanted to reiterate, trying not to do combination therapy with azithromycin, because there has been a lot of information publicity being given to that. So we are using single agent treatment for moderate to severely ill patients, and obviously mild folks we're just recommending observation.
Well, I can't thank you enough for taking the time out of what must be a very busy schedule. In HEMOC, we're busy enough, but in infectious disease, I can only imagine. And Dr. Shahid, thank you so much for joining us today.
Thank you so much. Stay safe. It's been my pleasure.
Yeah, likewise. You too. Thank you.
And that concludes the interview portion of our show this week. When we come back, Clinical Correlation with Dr. Ilana Yurkiewicz. Welcome back to Blood and Cancer. I am Nick Andrews. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. As I record this on Monday, Facebook reminded me that it's National Doctors Day. It did this by showing me a photo that I posted from exactly 2 years ago that made me smile. I had uploaded a photo of cupcakes with a card saying Happy Doctor's Day, and it was from the nurses on our inpatient hematology service. I remember vividly, those cupcakes were delicious. So today is National Doctor's Day. Today, I thank my friends and colleagues who are there during a pandemic and during all the other times, including attendings and all the doctors who remain in training, fellows, residents, and interns. Thank you to the behind-the-scenes doctors of hematology and oncology who the patients never get to see, the pathologists who read your biopsies, the radiologists who read your scans and say progressing or stable. And we are far from alone. So today on National Doctors Day, I also want to say thank you to the many, many nurses, respiratory therapists, physical therapists, occupational therapists, medical assistants, unit clerks, patient transport, cleaning staff, cafeteria workers, social workers, chaplains, case managers, pharmacists, lab techs. Teamwork makes our work possible. And thank you to the devoted family members and friends who are there for patients 24/7 more than any of us. I can't give every one of you cupcakes, but I see you, all of you. Thank you. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that's a wrap on episode 64 of Blood and Cancer, the official podcast of MDH Hematology Oncology. Let's get to this week's credits. Blood and Cancer is produced and hosted by the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. Blood and Cancer is produced by MDH executive editor, Mary Ellen Schneider. All of MDH podcasts are produced by our editor-in-chief, Dr. Ivan Aransky, as well as executive editor Kathy Skarbeck and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDH Podcasts, Nick Andrews.